Good afternoon, everybody. We were really pleased to be asked to spend a bit of time together on this call, reflecting on our collective experiences of a journey of change over the last 12 months or 18 months, leading the transformation of a cancer pathway in Greater Manchester, and hope that others that our experience resonates with others, and others can gain some insights from the experience that we've had. I think probably some introductions would help before we go forward. My name's Barney Schofield. I'm the Director of Planning and Delivery at the Northern Care Alliance NHS Group in Greater Manchester, Northern England, and I'm the Senior Responsible Owner for the Cancer Rapid Diagnostic Centre programme. Becky, would you like to go next?
Yes, hi, I'm Becky Duggan, and I'm the lead nurse for the Rapid Diagnostic Centre at the Northern Care Alliance. Anand?
Thank you. I'm Anand Iyer. I'm the Programme Manager working for the Northern Care Alliance, and I'm the Programme Manager for the Rapid Diagnostic Centre.
Hello, I'm Sykes. I'm the Rapid Diagnostic Programme Lead for Greater Manchester Cancer Alliance, who are the organisation that lead on this on behalf of Greater Manchester.
Thank you. I'll just try and set a bit of scene and a bit of context around the change journey that we're talking about before we move into exploring different dimensions of that journey and thinking about that in the context of system leadership, system convening, and programme management. Just for context, the Northern Care Alliance NHS Group is a group of hospitals and community services in the northern and the western part, northern and the eastern part of Manchester, comprising Salford, Bury, Rochdale, and Oldham localities. Greater Manchester Cancer is the Cancer Alliance for the Greater Manchester population, overseeing the system of care that delivers cancer care to patients in Manchester and beyond in some cases. I guess in kind of describing this, our sort of experiences of system convening and delivering this change management journey, I guess the irony wouldn't be lost on any of us that probably until quite recently we hadn't really heard of the concept of system convening, and we certainly weren't kind of using any sort of system convening checklist in practice. I think we were trying to follow perhaps the principles of the evidence-based principles of good programme management on our journey. But perhaps I think when we kind of look back down the road that we've travelled over the last 18 months, some of those key system convening principles and leadership principles do seem relevant. So perhaps we were kind of using some of that stuff intuitively as we went through the change journey, and therefore it's very helpful to have a kind of framework to think about that within. And I think the other thing to say would be I know for a fact that none of the four of us would pretend ourselves to be change gurus or experts at all in any of this. So. But I think please bear that in mind when you're listening to our collective experience of change. But we hope that some of our experience and collective wisdom resonates and is of some use to others. I mean, essentially, really, the change journey that we're describing is taking a really kind of small scale pilot test of change in a cancer pathway, right from the kind of edge of an organisation and of kind of peripheral interest into something that we've been able to really capture and scale and spread into a mainstream service model covering a population of roughly 1 million people in Manchester. Implement that and observe the results 9 months, kind of 10 months post implementation, and I think feel really pleased with where we've got to in terms of the emerging results in terms of patient experienced, kind of quality, staff experienced quality, and measurable impacts in terms of the time to diagnosis of cancer, which is outstripping and outperforming, you know, many of our existing cancer pathways. So really, that's the journey that we'll be trying to talk through today in a kind of coherent way that makes that accessible to others without expecting people to understand the nuances of Manchester, or indeed the nuances of cancer pathways, both of which are fairly labyrinthine issues. In the specifics are that we set up Manchester's first cancer rapid diagnostic centre, which went live in June 2020, focused on delivering a specific pathway for patients who present with vague symptoms, non-specific symptoms, which may indicate cancer, but who don't fit neatly into the existing tumour-specific diagnostic pathways. So that's what we've implemented. But by the end of the first year of operation, we're on track to see well over 1,000 patients through this new service model. And I think using this as an example, we'll try within this session to touch on perhaps kind of three of the principles of innovation and adoption and spread, particularly around complexity, around network-based leadership, around the value proposition, and perhaps kind of more generically sort of leadership and culture as a whole. Let's kind of get into the discussion. So I guess in kind of thinking, Sue, about the small scale kind of pilot that we really based our thinking around the Rapid Diagnostic Centre on. What do you think was kind of particularly interesting about that kind of pilot? What really kind of took us to think, actually, that's really small, but we could make that kind of really big and make a big difference?
And I think that the pilot was obviously for a period of 2 years. It was, as you say, very small scale, basically because that was dependent on CT scanning capacity, which at the time was limited. I think because the whole reason for having the pilot was to look at the inequity of provision for patients with vague or non-specific symptoms, in that when a patient presents with those vague symptoms, which might be a sign or a suspicion of cancer, evidence had shown previously that those patients got a poorer experience, a poorer outcome, and were usually diagnosed at a later stage, i.e. stage 3 or 4 of cancer, and quite often, in fact, can make up to 20 to 40% of the patients that actually get admitted via an emergency or via A&E. And so what the aim of that project was to do was to try and level up the care of those patients, or the diagnostic element of those patients, versus the ones who present with a more site-specific symptom, and where a GP would be very clear which referral route to put them on. And I think, interestingly, through that pilot, because we provided such a slick way of diagnosing patients, where you actually got, in the main, a yes/no to cancer within 5 to 7 days of receipt of referral, and that most of those tests were all done in the one day. What it then began to show, with very small volume, was that actually now those patients were getting a better service than those who would present with a site specific. So that then led us to think that, so what could we do to try and develop a service that could fit all? And really that ACE2, which is Accelerate, Coordinate, Evaluate, and that was funded by CRUK and sponsored by NHS England and Macmillan, really helped us provide a proof of concept for what then became the Rapid Diagnostic Centre initiative, which of course was has been led by NHS England and is a targeted programme, and there's a national directive to make it happen between now and 2024. Have I answered your question, Barney?
You have indeed, and I think it was particularly those the sorts of results that we were seeing about that from that pilot that encouraged us, actually, if we could scale that up and achieve that kind of level of accelerated diagnosis, not for the 4 patients a week in the mini pilot, which was only serving one particular part of our geography in Oldham, but actually if we could kind of spread that across a much bigger geography and see ultimately hundreds of patients a year, then what benefits could we achieve from that? And you might say, I guess it might be easy to say, well, we'd already got that small scale kind of proof of concept. We'd worked out kind of what that pathway might look like, and clearly there was a set of nationally definition over what a spread of that model into a rapid diagnostic centre model might look like, and therefore actually was that fairly kind of straightforward. Then you've actually got a national service specification which you need to apply kind of locally. That seems like quite a kind of straightforward thing, but I think our collective experience of that was pretty far from being straightforward. However, we were managed to kind of accelerate our way through all of this kind of ambiguity and complexity to go live just after the first peak of COVID in 2020, and therefore experience an impact when patients needed us the most. I mean, Anand, would you kind of would you agree that this meets a definition of a complex change journey?
Yes.
Why would you describe it as that?
Absolutely, 100%, Barney. I think what would be helpful to start off with is to provide some definition of the different type of tasks, like what's simple. So simple task is something which is straightforward in terms of achieving it. It's pretty much like, if I have to give an anecdotal example, it would be picking up a recipe book and baking a cake, which is a simple task. The next layer up is complicated, which is obviously you have a general guideline to achieve that particular task, but it's not straightforward. But again, with the right approach and with the right experience, you can do those tasks. And the complex tasks are the one. An example of a complex task is raising a child. You do have a general guideline in terms of how to do it, but there is no recipe book approach. There is a lot of local interpretation that's kind of needed and kind of have to do any kind of a complex task. So rightfully, I would say RDC was one of those tasks which just fit into that complex box. Because although there was this national guidelines and national approach, really, there was a lot of local variation. There was a lot of local approach that needed applying from an RDC principles point of view, and application of those principles at a local level. If we, again, from an RDC point of view, there is different layers of system convening and different layers of networking that we had to do. At the topmost layer was your NHS England, the policies emerging from NHS England, and which had to be interpreted locally at a regional level by GM Cancer, by Sue and other in Sue's team. And then next layer down, obviously, is the local interpretation of that at an NCA level. And there is different layers and different levels of networking that had to be done, which neatly fits RDC in that box of complex, that not a recipe book solution to how the RDC needs to be applied wider. So based on those points, Barney, I would definitely agree RDC clearly is one of those complex tasks that as NCA and as GM Cancer that we have delivered.
Yeah, that's very helpful. Thank you, Anand. And Becky, your background was as a critical care senior nurse within the Northern Care Alliance NHS group, and were appointed to clinically lead the Rapid Diagnostic Centre service, and really came into post only a small kind of number of months before we needed to, or weeks actually probably, before we needed to kind of get up and running. So, I mean, I think thinking about those kind of layers of system convening, I guess from my point of view, it's the local layer where the kind of rubber hits the road and where the door opens to patients. That was the kind of more complex end of that system to me. How did that kind of feel, I guess, kind of coming into post with already kind of some broad thinking about what we were kind of trying to do, developed, and a level of service definition in a business case, but still kind of a huge amount of ambiguity, and faced with the prospect of being there in clinic when patient number one kind of comes through the door.
It was exciting, in all honesty, and I think that's probably why this project has done so well, because amongst all the ambiguity and the change and the stress and all the hurdles to overcome, the underlying feeling around this whole project is that it's exciting, and that's why people get on board. Everyone understands, there's a clear vision, and there's really clear principles that underlie what we're doing. And I think the clarity in that goal and the underlying principles and how exciting those things are really helps to moderate the other not so exciting feelings around, the stress and the different challenges you've got to overcome. Yeah. We discussed sort of some of the challenges we've had to face in doing this, and they have been multifactorial, to say the least. There's been cross-site elements, dealing with completely different organisations and systems and ways of doing things. All the staff were new, including myself, but I actually think that's almost a positive in some ways, because you don't know how things did or didn't work in this area beforehand. So you're not sort of already in that tunnel vision of, well, this is how this happens. So, you're coming from a blank slate, really, and you just ask for what you need, and you don't know if that's a ludicrous ask or just a really reasonable ask. So you just ask everything in the same manner. So I think it was not scary at all, that's the wrong word, but it was unnerving, but also a benefit. I think everyone around the team shares decision making. It's not sort of this top down, decisions are made. It's a very inclusive way of working. And again, I think that makes everyone from really senior people in the team to more junior people in the team just feel really included, and that makes everyone give their absolute best, and really inspires them to work. Sorry, I'm looking at some notes because I think we've all had to be very, very adaptive. We find one issue, one solution, and then you're faced with 10 different issues that solution brings in itself. So you just have to keep adapting to everything. I think one thing that's really been useful, and I particularly have clung to in learning in this way, is that you only really need one really helpful, useful person in each area. And once you find that person, you cling on to them hard. And there normally is that person. And it may not be who you expect it to be, but there's someone in radiology that is useful. There's someone in booking that's useful. There's someone in digital that's useful and helpful. So as long as you make those.
I think you're right. But I guess those people have got to be kind of bought into the vision, haven't we? And I guess what we're talking about. Yeah. I guess what we're talking about, therefore, is a network, and in this program, I think those internal networks have been absolutely critical to mobilising a service and a pathway which crosses inputs from so many different areas. I think the wider networks between the Northern Care Alliance and the Greater Manchester Cancer Alliance, and between the Greater Manchester Cancer Alliance and NHS England, and the connectivity between all of those networks has been really kind of important for me as well. But I think right at the start, Becky, you said there that actually you felt, I think, excited and kind of, you know, energized by these prospects rather than either kind of, you know, too daunted. I'm sure there was a bit of that, or unconvinced, or any of the other kind of things that you might have kind of felt. What do we think that there was that wider kind of sense of an energized kind of community of individuals around this, and why do we think that was? Because actually this could have been, we've got some national service, we've got some national guidance that we've got some money to implement. We'll do that. My thought to kick us off is, I think we really believed ourselves kind of personally in what we were trying to do individually and collectively, and I think that inner motivation was very important.
I agree. Can I come in?
Yeah,
just
go
about
for it.
The work bit. It is. I think Becky said. Well, you've both said some really pertinent points. Is the excitement, and obviously I work with different teams as well, and we'll work with more as we go on. But I think from the very beginning of this, with the proof of concept with ACE2, it's been, and I had a privilege to project manage that, and then wanted to share the excitement, and then NHSE picked it up, and then obviously at the time we weren't sure how it was going to work, and then it's in engaging with the people, and you were the first people that I had to engage with, and then Manchester Foundation Trust. I think we've got that real good thing in place where there's the Cancer Alliance, and we're able to engage this way and that way, and up and down, and I think we've all been able to connect in different ways. So there's been networks with patients, there's been networks with other clinicians. We're able to sort of adapt and adopt some of those things, ensuring that the values of what we want to achieve are embedded within our network. So we want it to be a benefit to patients, we want it to be a benefit to the system and to the NHS system, and to assist in performance. I know, hate to say it, but it's true. We want it to assist clinicians in providing the best care, and we want to improve outcomes. So we all had those joint goals, and even though we didn't think of it perhaps in this way, like with system convening, the system convening is almost formalising what we were doing anyway. And I think it's, without wanting to sit and congratulate ourselves, what I'd just like to say is it's been a real pleasure that wherever you go, there is enthusiasm. So when I go to NHS England, there's enthusiasm. There's enthusiasm in the wider GM conurbation for this, and almost a very pleasurable envy of what you're doing. And then you have the enthusiasm as well. And I think the last thing I'd say is the connections, Becky, that you were mentioning. You've obviously also had to deal with the connections between primary and secondary care. And for any clinician who's only worked in one area, as it were, do you know what I mean? Has mainly worked in secondary care, which is me, and you, I think, has mainly worked in secondary care. Primary care is a very different ballgame, or vice versa. They've had to understand us as well, which then brings us having to take our values and our networks out there. And I think COVID has actually enabled us to do more and to stick together more, and for people to be more receptive of change.
I think that's right. I think there's something in what you're saying about the kind of some sort of kind of unifying vision that people bought into, which kind of which was about actually the value of the proposition,
Yeah.
rather than the proposition itself. And I think that helped to break down all sorts of internal and external organisational barriers. That kind of level of orientation around a kind of single shared goal. What do you think, Anand and Becky?
Yeah, I think if I may come in, I think my interpretation of all that is absolutely as you said, Barney. But I think one of the interpretation also was, I think the management or the approach of this was beyond the normal program management day-to-day stuff that we do. I think we had to do a lot of program management, but as your system convening Venn diagram represents, it's the program management on the left and it's system convening on the right. So we had all the right approach to program management in terms of having a clear, well-developed blueprint. We had a roadmap, how we're going to do it. We had an interim stage, we had a final stage. We had all the governance wrapped around it in terms of the program board, in terms of your GM board. And from a program management point of view, we also had that assurance, that internal assurance through the gateway reviews, which did help us. But then it wasn't just the program management side of it which helped us deliver this. I think it was also the system convening side of it, which was delivering that future perfect thinking to our colleagues. I know Becky mentioned earlier about you just need that one right person. And I think what you need to deliver to that one right person is that future perfect thinking of this is what the world would look like if we had to apply this. And there was that unifying of primary and secondary care, which you mentioned, Sue. And overall, Barney, it kind of took very much of a system leadership approach rather than a local leadership approach to delivering the program. And I think it's that nice connectivity between the program management and system convening is what made our program so successful, I believe.
Yeah, I couldn't agree more. And I do think you can't underplay the importance of that, in my experience, of that program management role, because I think being able to provide that and work within that evidence base and provide the assurance that what you're trying to do is well managed, that risks have been identified and issues have been identified and escalated appropriately, that the program is sticking to a number of defined objectives and working within a defined scope and remaining within financial parameters and so on. All of that stuff is really kind of important in having the headroom and the autonomy to go ahead and implement a change. So I certainly wouldn't underplay that. But I think you're right. I think our experience of the system convening bit, the kind of energizing of a number of kind of key stakeholders in and around this was fundamentally what allowed us to make such kind of rapid progress. Perhaps it was something about a kind of the scale of the ambition as well being quite big. Do you have any kind of thoughts on that, kind of what it was that kind of enabled to get that level of kind of energy, Becky?
I was just going to say, I think there's two things really, and very from in the early stages, before we had much understanding of what our results were going to be, there was just a very strong drive. Keep going. We won't take no for an answer. We are going to make this happen. It might not look like what we thought it was going to look like, but we'll work our way around it. And I think then very early on, once we'd gone live and started seeing results, both in the form of data, but performance and stuff, but also in the qualitative side from patient feedback, but also from clinician feedback as well. I think that really just got people on board quicker than anything else could have really. As soon as people started to see the benefits, they bought in. We had groups of clinicians that maybe had been skeptical when they couldn't really grasp the idea or fully understand what it would look like in reality. And as soon as it launched and we started getting that really good feedback and people could see what was happening, really potentially very skeptical people in the beginning, turned around and sort of started believing in the project. So I do think it's an easy project to believe in, because you can see so from such an early stage, like I say, on both a qualitative and a quantitative, that, you know, it's beneficial to everyone involved. So, you know, we're fortunate that that goes in our favour, really.
Absolutely. And I guess that's not to gloss over actually there's we've had a number of technical challenges. We've had a number of I think, you know, quite valid kind of different opinions about the relative priority given to patients with vague symptoms compared to patients with specific symptoms. We've had challenges around the governance around diagnostic pathways and radiology governance, which is very, very important. But actually, I think on the whole, we've managed to successfully navigate a number of those kind of technical and political challenges. I wonder if some of that is about about leadership style and leadership kind of culture as well. I think if we'd collectively gone at this with a kind of we must do this, it's a national mandate and it's a corporate instruction, therefore you will kind of comply, and that kind of highly like directive or kind of more autocratic approach, I'm not sure that we would have really got that level of kind of an emotional kind of connectivity and collective energy. So I think there must have been something about the kind of leadership approach and the culture that was conducive to creating the type of results that we've seen. How would you kind of like define or describe the sort of culture in and around the program and the leadership style? And clearly that leadership's distributed. It's the SRO. That's not me. That's, you know, all members of the program team. I don't know who wants to go first, but Becky.
And it's hard to just not throw buzzwords out at that point, isn't it? But you know, very open. Everyone listens. I mean, I've touched on it before, but you know, not a top down, and everyone listens and everyone's very adaptive. I think everyone sort of shoulders things together. You know, there's a lot of shared responsibility. It's not just reporting up the chain. You know, oh, there's this problem, I'll tell someone higher up. It's very much everyone at every level, you know, takes that on board. But I think obviously the impetus for that comes from the higher leadership. So it's a shared leadership, but that starts higher up as well. If that makes any sense.
Yeah, and maybe there's something about you've got to set the right tone or something like that. What do you think, Sue?
One of the words that comes to mind for me is trust. Yeah. So I've done lots of service improvement, as I know we all have in different ways, but from an alliance perspective, in that I feel, even though I'm not part of your NCA team, I've said this to you before, I feel part of the team. And I can see the trust between you guys as the more or less leadership team, aren't you, really? Whether that be program lead, SRO lead, clinical lead. I can see the trust between the wider team. There's a trust at your management board. There's an enthusiasm. And equally, I think I get the impression that you trust me as well. So Becky and I, over the last week, have had discussions about various clinical idiosyncrasies that have happened that quite understandably are happening 6 or 7 months in. So we had a protocol, but actually we've changed that bit. So this is changed. Now, I don't think I've worked with people who, in a climate where somebody has come to me in the role I'm in to tell me there's a problem. Do you see what I mean? It's usually when it's an alliance, you will keep it from. do you see where I'm coming from? So there's there's mutual trust. It goes back to the values, and I think it's about the shared values we have. We know that even if it only works to the point we're at now, and it won't, it'll work much bigger. but it's done a lot of good. And it's done a lot of good for all the 4 things that I've mentioned before: patients, system, clinicians. And we now need to prove that it's value in economically as well, which we will.
Yeah.
And so I suppose the main thing for me is trust and enjoyment and excitement. And I'm sure they don't fit with system convening.
No, but that's the truth, though. That's the truth, and I think it's I think because that trust exists as well. I think it's been a lot of fun. You know,
It has.
it has been. Yeah. What's your reflections on the kind of questions of leadership and culture and Anand? You're on mute. Can we trust you to come off mute, Anand?
Sorry, apologies. I couldn't agree more with Becky and Sue. And in fact, I don't think I've got much more to add, but I think a couple of things do kind of come to my mind is being collaborative and being open, as you've said, and it's more of a distributive leadership approach is what we've taken, Barney, in our approach. And also, I think it goes back to not necessarily micromanaging and not necessarily second guessing, because any innovation brings uncertainty, and with uncertainty there is no right or wrong answer sometimes. And I think sometimes you just have to trust, and you sometimes just don't have to second guess through it. And I think that comes through a distributive, open and collaborative leadership approach, rather than saying set in stone, this is what we need to do, this is how we're going to achieve, because there are different roads to reach our destination. I suppose there might not necessarily be the right or the wrong one, but as long as there is that trust, which you mentioned so earlier, as long as there is that trust that we are going to reach that destination, doesn't matter what the journey would be. I think that approach needs to be, has been applied in our leadership, to be fair.
Could I add?
Yeah, of course, so yeah.
What I've forgotten to do is I think I get the trust from NHS England as well. And although at times, I think we've all said, haven't we, that RDCs, you answer one question, you get 2 more. And that was the same in the ACE2 pilot as well. And although that can be like, oh, wearing, it's also exciting. But I think what NHS England RDC team have done is they've written the spec, but actually they've given us scope, and they're learning as much as we're learning. And what's been really innovative in a way from their perspective is that we have been allowed scope. Yeah. And that gives us freedom to then, as long as we keep in line with the principles, and I think they're all in our heads, tattooed, then we're okay, aren't we?
Yeah.
And
I think some of that trust, and I think some of that trust comes from that trust between the organisations. I think comes from the quality of the assurance. That is a personal view. I guess kind of what makes us all kind of collectively can trust each other might be a bit more difficult to kind of define. Really, it's a bit more sort of innate, isn't it? And I don't know why that would be. I guess it's got to be something about values and behaviours.
Yes.
Yeah.
And it's guts, isn't it? Sometimes as well. It's that. And then
it's a gut instinct, isn't it?
Yeah. It comes back to shared goals as well, doesn't it? All completely believing in what we're doing and working towards the same end goal.
Absolutely. So I hope that's been that discussion has been of interest to others. We're not pretending that the journey that we've been on, as I say, has been prescribed by any kind of specific change management methodology. It's been as much heart and instinct as it has been about the kind of the head and the kind of rational application of science. But I think whatever the kind of in different ingredients that create that change journey, there must have been a number of those kind of ingredients in place. I think to leave us where we are now with as I say, 8 or 9 months kind of post implementation of our rapid diagnostic service model, seeing such impressive results for higher volumes of patients than we'd anticipated. And I think the almost universal positive feedback that we're getting in terms of the patient experience, based on I think the coordination, the information, and the certainty that patients feel when they're going through this pathway, the speed of results, but also their own emotional connection with the members of the team. And I think also perhaps kind of one of the most gratifying issues for me has been to kind of hear the strength of the staff feedback as well. And right at the start of this journey, having a positive staff experience was always part of one of the core benefits that we wanted to achieve. But I think to hear Becky's colleagues describe who are experienced nursing staff who've worked in a number of different settings, describing the RDC as the best service that they've ever worked in, and I think finding the roles both satisfying but also developmentally and professionally kind of fulfilling has been a really positive benefit. What is it about the service, Becky, do you think that creates that positive experience for you and your colleagues?
It's being allowed to go the extra mile for the patients, and not being told to stick to a really prescribed way of working. You've got the freedom to do what you think's right for that patient and absolutely go the extra mile. And obviously some of that is we're not hugely constrained at the beginning of a new service. You have got that luxury of a bit of time and a bit of availability to do that. But actually, I think, to be honest, we will stick to those values even as we do get more time constrained, because it's really, really satisfying to work in a service where you all know you are doing absolutely everything you can to improve that patient's journey and life. It's not just about the cancer, it's about making every contact count and all of those things, but it really is. That's why it's satisfying, and also it's very varied. It might not sound like it would be, but it is. So yeah, it is a lovely place to work.
Great. Well, that sounds to me like a pretty good kind of full stop for this conversation. So I hope we've covered some ground that's of wider interest. If anybody's interested in hearing any more about our change journey, the contacts will be available on a slide, and we'd be delighted to hear from anybody. Thank you to NHS Horizons for giving us the platform to share our story. Thank you very much for listening.
Thank you.
Thank you.